Sorry to interrupt. I have a middle-aged woman with sudden onset blindness.
Hey, fellow eye nerds. In Season 2 of The Pitt, we see a very real, devastating, vision-threatening emergency called a central retinal artery occlusion, CRAO, or eye stroke. I was blown away by the realism and medical accuracy. But did you know that 20 years ago there was another show, perhaps not quite as regarded for accuracy, that also depicted CRAO? In this video, we'll talk about eye stroke, what we know about it in 2026, and analyze where these two shows got it right and where they might have gotten creative. As with all of these videos, here's your content and spoiler warning. Now, before we get started, what is a central retinal artery occlusion? Think of your eye like a camera. When light enters the eye, it gets focused onto the retina. The retina is actually composed of multiple layers. It is a very complex system of light sensors as well as neurons, which function almost as a very complex computer chip that synthesizes all of the information and then transmits it through the optic nerve back to the brain. Because the retina is living tissue, it requires blood to function. No blood flow, no retina function. On top of that, the retina is also very sensitive to changes in blood flow. The retina requires the most oxygen out of any tissue in the body, and all of that oxygen is supplied by one artery, a tiny branch of the internal carotid artery called the ophthalmic artery. Now, the ophthalmic artery then branches into the central retinal artery, which supplies the inside layers of the retina, and the posterior ciliary arteries, which supply the outer part of the retina. We'll focus on the central retinal artery in this video. A central retinal artery occlusion, or CRAO, is what happens when that small artery gets blocked.
This would be a central retinal artery occlusion.
In English, please?
A little blood clot can block the artery at the back of the eye and decrease your vision.
Sometimes it's called an eye stroke.
When the artery is blocked, the retina stops getting oxygen. Within minutes, the retina cells begin to die. Because there's no alternative blood supply, the damage is often fast and permanent. Animal studies indicate that damage to the retina may start as early as an hour and a half after occlusion, with permanent, irreversible damage occurring after 4 hours. Retina is actually brain tissue, and so therefore, blockages to the arteries that supply the retina function just the same as strokes to the brain. So what causes the blockage? Most of the time it's the same thing that causes other strokes and heart attacks. It could be a piece of cholesterol plaque that breaks off of the internal carotid artery in your neck. It could be a blood clot that forms in your heart that travels up and then gets lodged in that artery. But there could be other risk factors. For example, someone may have a tendency to create extra clots, a condition called a hypercoagulable state. However, there are also very common risk factors for developing these problems, things like high cholesterol, previous history of heart disease, high blood pressure, diabetes, history of smoking, and even heart rhythm problems such as atrial fibrillation. Even blood diseases such as sickle cell have been found to cause central retinal artery occlusion. There are some kinds of inflammation that can attack the blood vessels that can also cause a retinal artery occlusion. Although many of these inflammations tend to occur in young people, there's also a condition called giant cell arteritis that tends to affect people who are older than 50 years old. Giant cell arteritis can cause devastating vision loss by causing either blockage of the central retinal artery or blockage of the ophthalmic artery. And here's the part that matters most. CRAO is not just an eye problem. It's a warning sign. Studies show that people who have CRAO are at a much higher risk for developing strokes and heart attacks in the days to weeks that follow. In 2011 and 2013, the American Stroke Association and American Heart Association changed their definition of stroke to include retinal cell death, which includes central retinal artery occlusion. This represents a dramatic shift in how we understand central retinal artery occlusion. It's not just an eye problem. It's a stroke equivalent, meaning it should be treated with the same urgency as a stroke. So here's my first take-home point. If you or a loved one experience a sudden decrease in your vision, you should go get examined right away. Okay, now that we know what a CRAO actually is, let's get into it. I'm going to score both shows on 4 things: how the vision loss is presented, how they use or misuse a direct ophthalmoscope, how they depict the actual disease in the eye, and how they treat it.
Excuse me, someone? Help, please? There's something in my eye up at the top.
Which eye?
This one. What's happening?
It's all right. Just look down for me.
It's clear. There's nothing in it.
It's getting worse.
Is it fuzzy or?
No, it's dark. I can't see.
How many fingers?
I don't see any fingers.
And now?
I can see a little bit of light.
In both of these shows, the headline symptom is absolutely accurate. Sudden unilateral painless vision loss. There's no trauma, there's no warning, it just happens. This is absolutely textbook. But the degree of vision loss is where it gets interesting. And this is where I want to slow down, because most people don't realize that vision is not uniform across the entire visual field. And there are a lot of interesting details that the Pitt included depicting how doctors measure vision that might be overlooked. Think of our vision like image resolution. Your central vision, what you're using right now to watch this video, has incredibly high resolution. Your peripheral vision has a much lower resolution. And that's by design. If your peripheral vision was as sharp as your central vision, you'd be overwhelmed by everything happening at the edges of your view all the time. Different parts of your retina have different receptive field sizes. Smaller receptive field, sharper image. It's like the difference between an 8-bit video game and 4K. So when someone has a CRAO, what matters is not just that they lost vision, but how much of that high-resolution center they kept. And to talk about that, you need to know how we actually measure that. Chances are you've heard that normal vision is 20/20. But what does that really mean? Well, without getting too technical, let's think of this as a fraction. The top number represents what you can see at 20 feet, and the bottom represents what a person with normal vision is expected to see at the listed distance. So for 20/20 vision, this means that at 20 feet, you can see what someone with normal vision is expected to see at 20 feet. 20/40 vision means that whatever somebody sees at 40 feet, you have to get up to 20 feet in order to be able to see. As the bottom number gets bigger, this means your vision is worse.
Okay, well that's 2200.
Meaning?
What a healthy eye can see at 200 feet, she can see at 20 feet.
You know how each line on an eye chart is a different size? It turns out that the eye chart is calibrated for specific distances. As we learn from a young age, the closer we are to an object, the larger it will appear. And so if the eye chart is positioned at a distance other than the one that is calibrated, the bottom number will not be accurate. This will come up later in the video. There are, of course, variations to this measurement. In most of the world, the testing distance is measured in meters, not feet. And so the fraction for normal vision would be 6/6 rather than 20/20. The upper number can also change if we're testing at a distance that is different than the standard 20 feet. But that gets way more complicated. Regardless, this scale only works if you're able to read the letters on the chart. Once the vision drops below the level where the visual acuity is unable to be measured based on letters on a chart, ophthalmologists switch to a different scale. On most eye charts, the vision typically ranges from 20/20 to 2400. On the bad end of the eye chart, you have 2200, which represents the cutoff for legal blindness, or 2400, which is even worse than 2200. While there are other charts that may go higher up than that in terms of the size of the letters, usually once the vision is worse than 2400, we will switch to count fingers, which is when we hold up fingers over each eye and ask the patient to count how many fingers we hold up. If you cannot count how many fingers are being held up, the next level is hand motions, and that is when we check to see if you can detect a hand waving in front of your face over each eye. This tells us that you can detect motion, but not detail. If you cannot detect hand motion, the next level of vision is measured as light perception. That's when the ophthalmologist shines a light in your eye and asks if you're able to see the light. If you're not able to even detect the light at all, then you are classified as no light perception. And that is when you cannot see anything. Let's put this into perspective. There's already a huge gap between 2200 and count fingers. But there's another gap between count fingers and no light perception that is huge. This is not a continuous spectrum that is gradually getting worse. For somebody who has count fingers vision, most of the time they're still able to navigate a room and be able to make sure that they're not hitting very many obstacles. But somebody who can barely see light or can't see anything at all lives in near complete darkness. Scales like this are very important for helping us understand not only central retinal artery occlusion, but other diseases that can also severely affect our vision. When we start looking at some of the research that's done into central retinal artery occlusion, this scale helps you understand what we're talking about when we start looking at visual outcomes. Now here's the twist. I told you a minute ago that the retina has no backup supply, and that's mostly true. However, in about 1 in 4 people, there is a small extra blood vessel called the cilio-retinal artery, which supplies the center part of the retina and can preserve some of that central vision. However, in the 75% without that extra artery, central vision loss can be devastating, down to count fingers or worse. Now let's go back to that scale that I just showed you. In the Pitt, the patient reports light perception vision. She can tell light from dark, but nothing more. In-house, the patient is at no light perception. At the very bottom of the scale, total blackness in that eye. Both are medically plausible outcomes. Full occlusions without cilio-retinal sparing routinely produce vision this severe. So when we look at both shows, the severity of vision loss is not just played up for dramatic effect. It is, unfortunately, a common reality for CRAO. Let's talk about the scenes depicting the direct ophthalmoscope exam. Both shows mess up the exam in some significant ways, but are still pretty realistic. Taking a look inside the eye with a direct ophthalmoscope is, how do you say it, kind of cozy. The optics of the instrument require you to get within 1 or 2 inches of the eye. So proper technique is absolutely necessary to avoid some awkward situations. Take it from this instructional video by Dr. Jonathan Trobe.
Proper direct ophthalmoscopy requires good technique. Here are the steps. First, darken the room. Make sure you and the patient are comfortably seated. Hold the ophthalmoscope in your right hand to examine the right eye, in your left eye to examine the left eye. Approach the eye at a 15-degree angle, drawing as close to it as you can. Use your free hand as a guide, stopping when your instrument bumps against the knuckle of your thumb.
Now let's see how they did. The Pitt actually gets the eye-to-eye positioning right, but the doctor is holding the scope in the wrong hand for that eye. In-house, the hand positioning is wrong, and the doctor uses his right eye to examine the left eye, which would almost certainly lead to them bumping noses during the exam, if not more. The other critical part of this exam is that viewing the retina is best done when the pupil is dilated. Normally, our pupils constrict when lights are shined into our eyes. This reflex protects our retinas from super bright lights, but can make retina exams extra challenging. When ophthalmologists need to get a detailed look at the retina, we use eye drops that keep the pupils dilated. If you've ever had a dilated eye exam, you know that things are super bright until the drops wear off. However, in most hospital and ER settings, non-ophthalmologists usually don't dilate pupils. In these situations, the best practice is to turn off lights to dim the room, which allows the pupils to remain somewhat dilated for viewing. But as you can see in both shows, the overhead lights are still on. So when the doctor says,
"Hard to get a good look,"
I'll give them credit for trying, but they definitely made it much harder on themselves. Here's the thing though, even though I deducted points for correctness, I'm going to give them back some points for accuracy. And that's because incorrectly performing direct ophthalmoscopy is a real, well-documented problem in medicine. Direct ophthalmoscopy has a 175-year history, and it's still one of the hardest physical exam skills to perform well, even among trained physicians. Multiple studies have shown that it is inconsistently performed, and even when it is performed, it often fails to catch the pathology that's actually there. A prospective study at Emory University found that of the nearly 500 patients seen in their ED for headache between 2009 and 2011, fundus abnormalities were discovered in 8.5% of cases. However, direct ophthalmoscopy was rarely used, and when it was, it failed to detect any abnormalities. And this has nothing to do with the clinical abilities of non-ophthalmologists. We all recognize that direct ophthalmoscopy is a very difficult skill to master. Even in the typical eye setting, most of us don't pull out the direct ophthalmoscope for visualization. It's a very useful tool for us when we need it, but in a busy ER setting, this may not be the best way to look at the retina. So both shows accidentally nailed something that's actually true. Trying to perform direct ophthalmoscopy in a busy ER, under time pressure, without any dilation, in bright lighting, is one of the more error-prone areas of emergency medicine. They just demonstrated it through common mistakes. Now, before we move on to the next section, I wanted to highlight something the Pitt got absolutely right.
We need the FOP.
The what?
Now, I'll be honest, I didn't know what FOP meant in this scene, but a quick Google search told me that FOP means fundus on phone, and that's what I want to discuss.
Now we can see the whole retina without dilating the pupil.
There are tons of apps and devices that are available now to allow us to capture high-resolution color photos of the eye on smartphones, tablets, and computers, even without dilating the pupil. This can give us a much better quality view than the direct ophthalmoscope and is much more accessible to the non-ophthalmologist when examining the eye. This is cutting-edge technology that's not available in most hospitals. Despite over 15 years of data demonstrating the safety, effectiveness, and cost savings of fundus cameras, most ERs still rely on using a direct ophthalmoscope or asking an ophthalmologist to perform an in-person exam. I plan to make a separate video for this topic because it's such a game changer for eye care, but the Pitt deserves extra bonus points for this depiction. Now let's talk about what they actually show us as the inside part of the eye. The Pitt's image is spot on. The retina is pale, and there is a small red spot in the middle called the cherry red spot, which is a classic description of a real CRAO. If I pulled this image from a textbook, you wouldn't know the difference. The image shown on House doesn't match any single recognizable pathology. There's blood and a clot, but nothing that resembles a CRAO. It's so far off that I don't even know what they were trying to depict. Now, the Pitt never explicitly states the source of the clot, and that's pretty realistic. In real life, we don't usually know the source of the clot initially, though most are caused by a plaque from carotid blockage. The Pitt sneaks something into this episode that I think is incredibly subtle. Let's watch.
A little blood clot can block the artery at the back of the eye and decrease your vision.
Sometimes it's called an eye stroke.
Stroke? Like she could be paralyzed?
No, this would be limited to the eye.
That look of annoyance and explanation that CRAO is isolated to the eye is, in my opinion, a masterful performance. Now, I'm interpreting this look to be annoyance, and maybe I'm wrong, but perhaps it's a way to show some subtle frustration in using really alarming terms like stroke to our patients, especially when the diagnosis has not been established yet. Now, regardless of the reason, I think this was a really nice addition to the scene. Now, House goes somewhere much weirder. Although they don't say exactly how the patient got a CRAO, somehow it's connected to the final diagnosis of naphthalene poisoning. It's a really big stretch to believe that an improbable poisoning would cause an unlikely combination of bleeding and clot formation. So what should happen after a CRAO is diagnosed? Well, let's look at the evidence first. The full stroke equivalent workup includes neuroimaging, ideally a brain MRI, within 24 hours, a CTA or MRA of the carotid arteries, and evaluation at a stroke-capable center. That matters because up to 31% of CRAO patients have a silent recent stroke on brain imaging, even with no neurological symptoms. The Pitt orders a non-contrast head CT in the ED, a reasonable, realistic starting point.
Order non-contrast head CT.
What it doesn't show on the screen is the CTA or MRA or the brain MRI that should follow. And I think that's fair. In various interviews, the Pitt creators have stated that they meticulously research every aspect of a patient's workflow in an ER visit. An MRI can take up to 60 minutes, and that's not counting scheduling time as well as the time required for the radiologist to read the image. A lot of this workup happens throughout the course of a patient's hospital stay, not just in the ER. In-house, an echocardiogram and blood tests were ordered, chasing down endocarditis or an autoimmune cause. These are all reasonable diagnostic considerations for a teenager who is bleeding internally and has a stroke to the eye. But getting brain and carotid imaging are not mentioned at all. Now, there is some nuance there. The causes of CRAO are very different between a teenager and a middle-aged woman. That being said, House missed 2 other causes of CRAO that are very specific to this patient. He was in a car accident. Traumatic injuries can cause CRAO in a few different ways. For example, the wall of the carotid artery may get injured and partially split, called a dissection. Carotid dissections can disrupt blood flow and cause blood clots to form, much like the clots that cause CRAO. Small retinal infarcts can be caused by fat emboli from long bone fractures, where fat in the bone gets released into the bloodstream and then travels to the eye. In a later episode, the show depicts a stroke caused by fat emboli by this very mechanism. And now the treatment scenes. This is my favorite part. The Pitt discusses 2 treatments: ocular massage,
Digital massage, 10 seconds on, 5 seconds off.
and an informed consent conversation about intravenous thrombolysis, or TPA. So what do we mean by ocular massage? Well, ocular massage was first described in the 1880s. The rationale for ocular massage is purely mechanical. By rapidly changing the pressure inside the eye, it's thought that the lowering of pressure rapidly will cause the clot to move further downstream, thereby reducing the damage to the retina. Multiple techniques have been described for ocular massage. They all involve adding pressure to the eyeball for 10 to 15 seconds, followed by a rapid release, for a total of 3 to 5 minutes.
Digital massage, 10 seconds on, 5 seconds off.
Though it's a really quick line, you can see that the description of the ocular massage is 100% accurate. Ocular massage is still commonly attempted in CRAO. It's on the standard list alongside anterior chamber paracentesis, breathing into a paper bag, and a handful of older interventions. But here's the catch. Some meta-analyses have found that these treatments did no better than, and sometimes had worse visual acuity recovery than doing nothing at all, suggesting that these treatments may actually be harmful. Since most research into CRAO often involves using these treatments in the comparison group, it's hard to say exactly how ineffective these treatments actually are. And despite these discouraging stats, it's absolutely accurate that ocular massage and other similar treatments are still being used worldwide. The second treatment discussed in the Pitt is where it gets really interesting.
Thank you very much. Princess, bump central 13 to the front of the CT line.
What do you got?
Sudden onset blindness patient has central retinal artery occlusion. I just spoke to an ophthalmologist at the VA, principal investigator for thrombolytics in cases like this.
Not exactly standard of care, kind of risky.
We'll do informed consent. It's our best shot at saving some of her vision.
Your patient, your call.
The Pitt introduces this treatment, intravenous thrombolysis, as a highly experimental treatment for CRAO, and this is largely true. Medical thrombolysis, or clot-busting medications, work by dissolving existing clots. They've been used in the treatment of acute brain stroke as well as other clot-related conditions, sometimes with miraculous effects. Although there are many formulations, they're all based off of tissue plasminogen activator, or TPA, which breaks down the main protein in blood clots. Over the past 20 to 25 years, doctors around the world have been doing careful research into seeing whether these medications, which have been helpful for brain strokes, might be helpful in CRAO. There have been some promising results, but the studies reported on small groups, far too inconclusive to make a blanket recommendation. 2 recent multi-center double-blinded randomized control trials sought to answer this question of efficacy. The verdict, unfortunately, a little bit more disappointing than promising. Both studies found that there was no benefit for using intravenous thrombolysis for CRAO, and there was a concerning risk for brain bleeds. However, both studies were still quite small, so additional studies with larger numbers are recommended. But that's probably too much detail for this video. Suffice to say, the jury's still out, but it's not looking good for thrombolysis at the moment.
Not exactly standard of care, kind of risky.
We'll do informed consent. It's our best shot at saving some of her vision.
Your patient, your call.
The approach to discussing the use of IV thrombolytics in this situation is spot on. As we've discussed, there is no unequivocally proven treatment for CRAO. Even ocular massage is not proven and may be harmful. In these situations, if the treatment has some supported research but is not accepted as the standard, doctors often have a careful discussion with the patient about the risks and benefits so that they can make an informed joint decision.
We have a decision to make.
Studies have shown that some vision can be restored with a clot-busting medication,
So get it.
but there are possible risks. For eye stroke, only 17% get better without any treatment.
Only 17%?
Yes, but with the medicine, another 20% can improve.
So where did the Pitt come up with these numbers? As I was preparing this video, I went back to some recent CRAO papers and found this. This is a 2020 paper in the journal Stroke, a non-randomized observational cohort study and updated patient-level meta-analysis. Among the 16 patients treated at Vanderbilt University, 43.8% of patients treated with IV thrombolytics or alteplase within 4.5 hours recovered vision to 2100 or better, compared to 13.7% of untreated patients. When pooling outcomes across studies, it was 37% with treatment versus 17% without. These are essentially the same numbers the Pitt put on screen. Whoever wrote this did their homework.
But there can be complications. 2% of patients who receive the medication get worse, and 1% have severe disability or death.
The Pitt accurately described the risks of thrombolysis as well. Remember how I told you that 31% of patients with CRAO have silent strokes in their brains? It turns out that if you have recent strokes that are already healing and you give a clot-busting medication, it can actually make things worse. In the worst case scenario, it can cause permanent deficits from additional strokes or even death. This is why before administering thrombolytics, doctors will get a thorough medical history as well as brain imaging to screen for bleeding disorders or recent strokes.
That's 20 mg TNK.
This is where the Pitt goes slightly off script. Even though it's depicted that the CT is expedited,
Princess, bump central 13 to the front of the CT line.
they don't show whether or not the results have come back before administering the medication. The other nitpicky thing I want to point out is that the Pitt stretches the medical evidence just a little bit. TNK, or tenecteplase, is one of the many thrombolytics used today. However, the article in Stroke used alteplase, a similar but still different medication. It's not a major issue, but when we look at how to apply results from research to clinical practice, it matters a lot. Because the study did not investigate tenecteplase, we can't be absolutely certain that the 37% versus 17% figure holds true. With all that being said, the Pitt does a tremendous job of presenting accurate, up-to-date, and evidence-based data on a promising yet controversial treatment for CRAO. Now let's focus on a different part of the treatment discussion. There's a detail buried in the statistic that I think is very important, and it's easy to miss if you just hear 37% recovered.
I could sort of make out your hand.
Can you cover your good eye? How many fingers am I holding up?
3.
That's good news.
So the medicine worked? She's out of the woods?
Possibly. It's
To give us some perspective, all patients in this study had to have CRAO with vision worse than 2200. Remember the vision chart we looked at earlier. 2200 is the cutoff for legal blindness. Recovery in this study has a specific defined endpoint, vision improving to 2100 or better. 2100 is still significantly worse than 20/20 vision. It means a patient can read the big letters, function, maybe even drive with restrictions in some states as long as it is only in one eye, but it is nowhere close to 20/20. This is not the patient sees perfectly again. This is the patient had essentially no vision, but now has some usable functional vision back. And that's a very realistic endpoint. It's not to say that a patient can't recover back to 20/20, it's just that the study had a much broader view of recovery.
Give it a minute.
I can see.
In-house, the patient's vision is completely restored with a crazy treatment we'll get into in a little bit. Although this is possible, it's not very likely. I have one more nitpick on the Pitt while we're here, because this is the type of detail that only an eye doctor will notice. When the doctor goes back to check the vision after treatment, the exam sequence is mostly accurate. The doctor starts with counting fingers, which is a good place to start. However, once we move to testing reading vision with a near card, the card is being held several feet away from the patient, past the end of the bed. Near cards are specifically standardized to be held at near distance, which is typically around 14 to 16 inches, because that's the distance the chart's letter sizes are calibrated for. If you're holding a near card across the room, you're no longer measuring near vision correctly.
Okay, well that's 2200.
I want to emphasize that this discussion of thrombolytics and CRAO is extremely nuanced, and there's a lot more we could discuss that goes outside the scope of this video. Although the Pitt shows results from a reputable research study, it's not definitive. It's compelling, but it's not proof. There's also legitimate evidence that suggests that thrombolytics may not be as effective as we had hoped and may even be harmful. So while thrombolytics and CRAO are still considered a promising treatment, the data isn't conclusive, and its use varies widely among institutions. Now let's talk about House. I have a lot to say about this scene. I remember seeing this episode when I was a pre-med student and thinking this was pretty incredible. But knowing what I know now, this is pretty cringy.
Also, I have an idea for his eye.
Nothing we can do about his eye.
He's got a clot
Put
in
it
the
in a memo.
If we remove some of the liquid from the eye itself, the vitreous humor, it might make some extra room around the retinal artery.
If the artery expands, the clot might move on its own. It's very creative. Why didn't you mention this before?
I didn't think of it before.
You should have.
The rationale is not far off from the one proposed for ocular massage. By rapidly reducing the pressure inside the eye, more room is created around the artery to allow the clot to move further downstream. At least that makes sense in theory. There's a similar procedure that some surgeons will do when trying to treat CRAO. It's called an anterior chamber paracentesis, or AC tap. It was mentioned in the previous list of treatments that don't work well. But the vitreous is very different from aqueous, and we'll get into that here in a little bit. First, let's talk about the procedure. A vitreous tap is a real thing. However, we don't typically do it for CRAO. There are several reasons why an AC tap is preferable over a vitreous tap. As the name implies, aqueous is mostly water, ions, and protein. Vitreous is also mostly made out of water, but it contains molecules similar to those found in jello, which make it sticky and thick. Vitreous is also thicker when you're younger, so it's even much more difficult to pull any substantial amount out of the eye. Vitreous is partially attached to the retina, whereas aqueous freely floats inside the eye. Because of this attachment, vitreous taps carry an inherent risk for retinal tears or detachments, which is not ideal. Unlike what's shown here, most vitreous taps are not done with direct visualization of the vitreous. Most of them are done in the office under sterile conditions with shorter needles. Now, AC taps are much better at direct visualization. So even though the rationale is reasonable, they chose the wrong compartment. But let's say they did an AC tap instead. The research still tells us that these are not very helpful. To be fair, a lot of this research did not come out until after the episode aired, so I'll give them back a few points because the medical evidence was not quite as definite. Now let's have some fun looking at the way they did this vitreous tap. Like I said, we usually don't do vitreous taps in the OR. We still use sterile technique, but it usually doesn't require this elaborate of a setup. However, if we were going to go to the OR for a vitreous tap, we would probably put a drape over the rest of the patient's face so that only the eye was covered. This helps keep respiratory secretion, saliva, and other contaminants from getting into the eye. House is one of the better shows at depicting sterile procedures, so I'll give them a pass. Now, whenever we do procedures on the eye, we often will use a lid speculum to help hold the eyelids open. If the procedure is very quick, we might not have to use a lid speculum. However, with a vitreous tap, because it's a little bit more involved and you need better exposure, I would probably use a lid speculum in this case. First, props to the production team for making it look like they actually stuck something in this guy's eyeball. However, watch the angles of the needles as they enter the eye. The needles are pretty parallel with the iris, which is the colored portion of the eye. That's the wrong angle for a vitreous tap. The lens sits just behind the iris inside the eye, so any needles inserted towards the vitreous cavity have to be directed further back to avoid damaging the lens. If a needle punctures the lens, an instant cataract forms and can result in inflammation and all sorts of other issues. This is still better than a different episode where they perform a retinal biopsy by passing a needle straight through the cornea and the lens. But that's a completely different video. What's interesting is that this is the technique that we use for an AC tap instead of a vitreous tap. By keeping the needle shallow, it avoids hitting the iris and the lens. So it's kind of right, but it's really wrong. Now, for the record, there is no slurping sound with a vitreous tap. So putting it all together, we have the wrong compartment, weird setup, and bad angle. As expected, the Pitt lives up to the reputation of being the most medically accurate show to date, and House still wins the weirdest case award. There was a lot to talk about in these shows, but I don't want to get lost in all of the nitpicking. So here are 4 things that we should take away from all of this discussion. We've been calling CRAO an eye stroke, and that's accurate, but it can still come across as being just an eye problem. As we've learned, CRAO is considered a stroke equivalent, the same urgency as a brain stroke. People with CRAO have a high risk of developing a brain stroke or heart attack in the days to weeks that follow. For some patients, CRAO is life-threatening, or at minimum, a warning sign. Both shows got this right. This is a true emergency, not something that can wait for an appointment. Time matters here in 3 different ways. First, time for evaluation. Getting seen, getting diagnosed, getting imaging. All of that needs to happen fast. And there are significant barriers to getting that evaluation done quickly in the real world. Access to emergency care, access to ophthalmology, recognizing the symptom as an emergency in the first place. All of that deserves its own video. Second, time for intervention. Retinal tissue begins to die within 1.5 to 4 hours of losing blood supply, if not sooner. Even though using TPA in CRAO seems promising, the treatment window is very narrow, and as we've discussed, it's not proven science. But if there's any chance for improvement, earlier treatment matters. Last but not least, time matters for long-term prognosis. Like we just said, the risk for brain stroke and heart attack is high after a CRAO. A CRAO is not something that just happens to your eye. It's evidence that something bad is happening to your vascular system, and that could affect your brain and heart. That's why the workup matters so much, even if the vision can't be saved. Finding and treating the underlying cause can be life-saving. We also talked about how we measure vision and how that applies to understanding the research around CRAO outcomes. Not everyone with CRAO ends with total darkness. Some have cilioretinal arteries that preserve their central vision. Some have partial recovery even without any treatment. Some will end up like the patient that was shown on the Pitt, where there is some improvement, not 20/20, but still better than where they started. However, some end with severe permanent vision loss. The point is that understanding different levels of vision loss is how doctors actually communicate prognosis, set expectations, and decide what kinds of support a patient needs going forward. And finally, looking inside the eye, especially with a direct ophthalmoscope, is hard, not just for TV doctors, but real physicians, including ophthalmologists. We've talked about the data already. This is one of the most error-prone exams in medicine, with several studies showing that it is inconsistently performed and often fails to show the pathology that's actually there. And this isn't a knock on any doctor or specialty. It highlights just how difficult it is to capture accurate information about the eyes without the proper tools. My takeaway is this: despite all of the advances we've made in visualizing the retina, many healthcare systems are still relying on 175-year tech that is difficult to use and interpret. By using a fundus camera to diagnose CRAO, the Pitt is showing an ideal situation in which the ER is using the most up-to-date evidence-based workflows. I hope their example will inspire other hospitals to adopt this potentially life-saving and vision-saving practice. For more information about retinal artery occlusion, visit the American Academy of Ophthalmology's iSmart webpage. I'll drop that link below. If you or someone you know is living with vision loss, the National Eye Institute has a dedicated low vision resource hub that I'll link below as well. I had a lot of fun analyzing these two shows. If you want to see more videos like this, let me know in the comments below what show you'd like me to analyze next. Thanks for watching. See you next time.